Welcome to a podcast brought to you by the American Academy of Orthopedic Manual Physical Therapists. Our academy is a national organization committed to excellence in orthopedic manual physical therapy practice, education, and research, and we're here to explore a wide range of topics with you through interviews with content experts.
Welcome, listeners, to another podcast by AOMPS. I am Kevin MacPherson, and today we are going to be interviewing Dr. Michael Schneider. Dr. Schneider is an associate professor in the Department of Physical Therapy, as well as the Clinical and Translational Science Institute at the University of Pittsburgh. He also is a member of the Institutional Review Board at Pitt, and he is an advisory panel member to the Patient-Centered Outcomes Research Institute, which is better known as PCORI. And PCORI does provide funding for research and happens to be one of the funders for Dr. Schneider's article that we're discussing today, which is titled Comparative Clinical Effectiveness of Non-Surgical Treatment Methods in Patients with Lumbar Spinal Stenosis, a Randomized Clinical Trial. Now, this article was published through JAMA Open Network, and this esteemed publisher, or this esteemed journal, does provide free access to these articles, so feel free to run out and download it. Now, before I go too far ahead into the interview, real quick background on Dr. Schneider. He is our first guest who is not a physical or physiotherapist by training. He is a doctor of chiropractic, of which he received his initial degree in 1982, but then went back to get his PhD in rehabilitative science through the University of Pittsburgh in 2008, and has a long history of clinical practice prior to transitioning into a purely academic role. So, Mike, if you don't mind starting off, do you mind giving us just a short synopsis of your project and kind of some of the results in a way that both our research listeners as well as our clinical listeners can get your take-home message from?
Sure. Yeah. So we had a randomized trial, and the patients that we were looking at were all patients who had diagnosed with lumbar spinal stenosis, mild and moderate. We did not include any patients who were severe enough to require surgery. And the reason we did that is because there's prior studies. You're probably aware that Tony DeLito here from the University of Pittsburgh did a trial comparing physical therapy treatment with surgical treatment. The problem with that is that, to just think about it, the person who would agree to be randomized there is somebody who's so severe that they have nothing to lose. They're already they're ready to be operated on. We didn't want that. Our question was, let's take people who clearly don't need an operation and then look at what different types of treatments might work best with them.
Okay.
So we had three groups in our trial. It was a randomized trial. We had about 260 patients that we randomized. We had a few dropouts, so we had about 80 per group. And the groups were first a medical care arm, and people randomized to that arm saw a physical medicine doc who treated them the way you would expect, right? Gave them oral medications. If that didn't work, they got an epidural. Only about 20% of those patients actually went on to have an epidural. Most of them were managed with meds, kind of like what you would expect from a physical medicine doc. The other group was what we call our manual therapy and individualized exercise group. And we did this on purpose. We had two chiropractors and two physical therapists delivering the manual therapy and individual exercise. And we did that for design because we didn't want this to be seen as a chiropractic study or a physical therapy study. We wanted to be seen as a manual therapy and a profession agnostic study, if you will. And in that arm, the patients came in twice a week for 6 weeks. So they came in twice a week and got a combination of manual therapy, and then the exercises were kind of individualized to that patient. Although what was not individualized is that we put on an exercise bike as part of their sessions. And I can explain the manual therapy in more detail later. Our third group was a group exercise group, and this was kind of novel. People who were randomized to this arm, we just gave them a membership to a local Y or JCC where they had like silver sneakers type classes. And we just told them, we want you to go to 2 classes a week for 6 weeks. So rather than getting the individualized instruction, they just showed up and did like calisthenics for seniors. It was not specific to lumbar spinal stenosis. And there, the research idea was maybe just activating these people, getting them more physically active, would have a treatment effect. And so those were our three arms.
Okay. Before you get into the results, just I'm curious and I want to make sure that the listeners, as well as myself, have a clear delineation. What were you using as your cutoff for mild, moderate, and severe for our LSS patients here?
Very simple. I mean, we used first of all, everybody had MRI or CT evidence of anatomical stenosis, which, by the way, the prevalence is huge, right? It's almost like your
Yeah.
age. If you're in your 60s, 60% of people are going to have lumbar spinal stenosis on an MRI. If you're in your 70s, it's 70%, 80%. So that imaging wasn't enough for us. We wanted them to have the clinical syndrome of stenosis where they had claudication upon walking.
Mhm.
And very simple, mild or moderate meant not severe. In other words, did your doctor say you need to see a surgeon? No. Okay, then it's not severe. I mean, it was that
Gotcha.
simple.
Gotcha. Now, so let's move into the results. Let's move into the findings that you had. That way, we've got kind of our base of reference to go back to. Then I can ask you a little bit more about some of the interventions that were performed, if you don't mind.
Sure. Yeah, and by the way, you mentioned this before. This paper was published in the online version of JAMA. It's called JAMA Network Open. It was published like January 4th of this year, and it's a complete open access, full text for anybody. So anybody who wants details can just pull that up and read it. But the bottom line results were that it was kind of surprised us that actually in all three groups, patients improved. Our main outcome measure was two things: the self-reported Swiss spinal stenosis questionnaire, which a lot of therapists are not familiar with, but it's essentially an oswestry for people who have stenosis. The questions are more specific to lumbar spinal stenosis. And self-report question with 12, it has 12 questions instead of 10, like the oswestry. And then we also did a self-paced walking test, which is an objective measure of walking performance. And there it's very simple. We basically tell the patients, we want you to walk, and we have a track in our research facility. Walk around this track, and when your legs are bothering you like they would in normal life, and you have to sit down, just sit down. And we measured the distance that they walked and the time that they walked. And so what we found is that, and this is kind of music to our ears, right? As physical therapists and chiropractors, the group that saw the physical therapists and chiropractors had the best results at the 2-month mark, which was our primary outcome. At 6 months, they maintained those gains. But what's interesting was that even the people who had the medical care and group exercise, they also improved at that 2-month mark. Not quite as well, but at 6 months, everybody kind of looked the same.
Mm-hmm. And you made it you alluded to a possibility for that shared outcome or that shared beneficial outcome. What did you think was going on that could be one possible explanation for why you saw that across all three groups?
Well, there's a couple of reasons why I think this is the case. First of all, we all know that patients who enter into research studies are different than people who don't, right? They might be a little bit more motivated. There's an expectation that anything you do in a research study is going to be helpful. And so I think this gets into the kind of that psychosocial model, right? That patients who came into this research study, their expectations were up. They were encouraged to stay in there. They got a lot of attention from the research staff. Our medical doctor who treated them had a great personality and was very conservative, kind of medical physician who did what you're supposed to do, which is have shared decision making with the patients. He didn't force anything on anybody and followed maybe not the way that we would expect things to be done in a busy clinic that wasn't a research clinic. One of the things was interesting about the group exercise component. That's where we had the most dropouts, which is probably not surprising. But the people who stayed in that group, right, did very well. And we asked them at the end, and they said, you know what, these exercises helped me a little bit, but you know what really helped me was I was feeling kind of down on myself. I was staying at home, feeling isolated. Once I started doing these exercises, I met some friends, and I start staying here, having lunch. So the social aspect of group exercise seems to have a treatment effect.
Hmm.
And so we're in the process now of doing a secondary analysis. I think this is interesting, right? That maybe for the person who was not socially isolated, they wouldn't have as much of a treatment effect with group exercise. You see what I'm saying? So
Hmm.
there might be subgroups here
Yeah.
that respond to the different arms of the trial.
That's so I find that interesting. I just recently, and this is a little bit off task, so if I need to, I'll take it out. But I just recently provided a review of the literature in a 1 hour lecture for our local PT association here, and it was on exercise adherence. And one of the articles that I cited in there found that the social component of their aftercare, so they've progressed away from the structured exercise prescription to the 2 year continue to follow them without any specific intervention. And one of the things that they found most beneficial was that social aspect in their research paradigm, or the way that they set up that study. And I mean, that does seem to be kind of the premise behind a lot of our more healthy model exercise based classes, such as a CrossFit or a similar
That's right.
methodology. Yeah, and so like it gets me thinking as a clinician, is there a way, HIPAA aside, to start to create kind of that exercise class where I am trying to pair my similar patient presentations to each other, and they can come and work out and develop that as well as receive a structured
An
intervention here
exercise
and there.
buddy.
So yeah, exactly,
I like
exactly.
that idea.
So I'm kind of I'm interested because one of the big things that jumps out to me from that psychosocial aspect was that with that physical medicine physician, we were looking at I'm sorry, it was only a couple of sessions with him, whereas we were getting 2 times per week with the other. Uh, do you feel that it just seems to me like I would expect them to need to be seen more frequently as opposed to there being such a difference between the three groups there?
Yeah. So to speak about the medical group, I think well, so what happened there? They went to see the physician 3 times. So they went in once. At 3 weeks, they had a second visit, and at 6 weeks. So that was a 6 week period as well, but they were only seen 3 times. Um,
Mm-hmm.
but I think as we know, patients when they interact with a physician have a different expectation and sort of, I hate to say this, but it's true, right? They have more of a respect for what a physician says than a non-physician for some reason. So maybe his words are more
Agreed.
powerful. One of the things we also allowed him to do was have sort of a pragmatic approach with the medications. And one of the things he did, which I thought was very interesting, was he took a lot of people off medications, right? So one of his principles was, hey, Kevin, I see you're taking 8 different medications here for your stenosis and other conditions. I think we need to trim some of the stuff back. And
Mm-hmm.
he also
Yeah.
tailored the meds better. So he, rather than just dealing with the pain, he would say, Kevin, what's your sleep like? Oh, I'm glad you mentioned, because when I have a bad night's sleep, I'm much worse the next day. Well, let's give you some meds to manage your sleep a little bit better. If he saw the patients were depressed, he would give them low dose antidepressants. So I think his approach was a much more tailored and individualized medical approach than most physicians would do. We wanted to be usual medical care. We thought that'd be our control group, but he did such a good job that it surprised us. And he also encouraged them to stay active, and that it was okay to exercise and it was okay to move. We found out that a lot of patients were, that fear avoidant model, right? I'm old, I'm frail. Maybe I shouldn't. When I walk, my legs hurt, so maybe I should walk less. So as simple as it sounds, going to a physician who says, "No, Kevin, don't sit around the house. Even though your legs hurt doesn't equal harm." Right? It's what physical therapists say all the time. And this physician was saying that to the patients. And so, even though it was only 3 visits over 6 weeks, that was reinforced. Hey, are you walking? Are you trying to work through your pain? It's okay to do that. That was the message they were getting from I think all 3 groups actually.
That helps me understand the results quite a bit better. And also, I think that is a story that is very well played out for our listeners to get that bigger picture. And it's not quite as sterile as research literature can be for our clinical audience. Well, I was going to jump to a different question, but I want to make sure you get a chance to respond if you had one for that one.
Well, I don't think we can underestimate the effect of the what we say to patients. We had some patients tell us that when they got randomized to the group exercise, they kind of flinched a little bit and then would say, well, "What is there a problem?" Well, yeah, my primary care doc said, it's not safe for an old person like me to exercise. And I almost fall off my chair. I'm like, I feel like saying, "What? WTF?" I mean, your doctor told you not to exercise? Well, yeah, they said I have osteoporosis and I have a heart condition and maybe I should be careful. Well, yeah, maybe you should be careful, but it's okay to, go to these exercise classes. And we had to kind of encourage them a little bit. Um, that was surprising to me to hear how many older adults are being told by their primary care docs, you shouldn't exercise, or putting doubt in their mind. And if they see another physician who says, no, 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 your primary care doc was looking out for you, but it's okay to exercise, I wonder how much just that one sentence has as far as the treatment effect is concerned.
To really break down some of that built-in fragility
Yeah.
is important, especially since again I'm never been very good with drawing the researcher's name, but I remember the studies. And there's a recent study where they looked at osteoporotic patients and they gave them really heavy deadlifts, close to 80% of their 1RM, and they trained them at that level, and they had zero adverse events, zero fractures, lots of improvement when they looked at the Z scores. So that idea of fragility, I'm hopeful that as we continue to get information both from you as well as other researchers, that we can start to break down some of that.
Well, that's sort of a hidden piece of our paper. I'm glad it's a good segue into this, right? So we reported our adverse events in a table, in our paper, and we had no serious adverse events. Our adverse events were common, mild ones. For example, no surprise, people who were treated by the physical therapists and chiropractors, like half of them reported being sore the next day. But that was a transient soreness that lasted less than 48 hours. And in fact, surprisingly, a lot of these older adults said, yeah, I was really sore after that. It's like, oh, shoot, I have to record an adverse event. Yeah, but Dr. Schneider, it was a great soreness. I haven't felt that sore in years. I'm really glad they worked me over hard. And and then that leads to an APTA choosing wisely statement, right? That physical therapists are underdosing older adults. That's what our patients were telling us. They're like, I'm so glad that this physical therapist, put their hands on me and pushed me and stretched me and hurt me because, I've been to therapists before that treat me with kid gloves. What do they think? I'm old or something? And of course they are old, but
Yep.
it's a very interesting statement, isn't it? That the patients are perceiving that the physical therapists that are treating them and the chiropractors are holding back. And when we actually interviewed chiropractors and physical therapists independently, and they told us the same thing. We asked physical therapists and chiropractors, how confident are you in treating a patient with lumbar spinal stenosis? Well, I'm not very that confident because it's a chronic degenerative condition. I don't really know what I can do for them. I'm like, oh my gosh, that lack of confidence is probably spilling over in nonverbal communication to your patient. And then we ask them, do you find? Look, I'll be honest with us. Do you kind of hold back a little when you do your? Oh yeah. Why are you holding back? Well, I don't want to hurt them. I don't want to break, their osteoporotic. Well, it's not like you're either soft touch or jumping on them. Isn't there something in between? And we start to flesh that out in our study. We
Mm-hmm.
started seeing that therapists and chiropractors tend to hold back. And again, we're not saying to completely disregard frailty and osteoporosis, but I think the pendulum has swung a little too far to underdosing these patients, and it has to swing back more to the middle.
So jumping into this, I'm curious because when I looked at the supplement, which broke down your protocol, in that exercise group, I would argue that what I read, and this could be just my bias in how I read it, it seemed to be very light. It seemed to be very guarded prescription in that group. Am I just reading that wrong?
Yeah, it's not guarded at all. In fact, um, one of my co-investigator there, Carlo Amendolia, the second guy listed co-author, he ran a similar trial. He's from the University of Toronto, um, and he's developed a program called the Boot Camp for lumbar spinal stenosis, and that's literally how he treats his patients. And our protocol is modeled after his boot camp approach. So we don't hold back anything with these patients, right? They come in and we put them on an exercise bike. We stretch and mobilize every joint in their body if they can take it. And so it's not a heavy strengthening type of protocol, if that's what you're leading up to.
Just that general exercise group. I kind of heard bands, I heard giving the person options to sit and whatnot. It gave me the impression as the reader that, well, this was a little bit more, for lack of a nicer term, kid glove. But what you're describing seems different. It seems like you were pushing them into harder reps with some of the resistance training. Is that correct?
I'm sorry, which arm of the study?
With the general exercise, the exercise groups, so not the manual therapy and
Yeah,
individualized.
so the general exercise group, and it didn't come out well in the article because of word limitations.
Hmm.
What we did was, if you're familiar with some of these group exercise programs for older adults, Silver Sneakers is just one of them, right? There's many others.
Hmm.
So when we gave them a membership, we gave them a 3-month membership to these gyms and told them they had to go twice a week for 6
Hmm.
weeks. But if they wanted to continue, they were allowed to. We let them self-select what level of exercise they wanted to do.
Okay.
So some people went in and they did like the lowest level Silver Sneakers class,
Mhm.
and after one session, they like, this is too easy for me. I want something more difficult,
Okay.
and they would self-select what level of exercise they wanted to do.
Hmm. Okay.
So some of them started at level 1, they jumped up to level 2. Some started at level 3 and said that's too hard, I'm going to drop down to 2. And people did different things.
Gotcha. And that is rewarding for you to also throw in that some of the limitation with my interpretation of that study is also coming from a word count issue, not being able to fully explain that, which I think some of our clinicians, self included, prior to really getting involved with this podcast, would say like, well, why didn't they do this? Why didn't they do that? And it does seem to be that you can't write War and Peace as an article. You've got to write a short story.
Yeah,
So
that's an understatement, right? And then the headlines that they force you to give sometimes are misinterpreted as well.
I can only imagine. So, moving on to the manual therapy group. With the manual therapy and individualized exercise group, it sounded like there were some restrictions on where manual therapy could be applied, or is that also something I just interpreted wrong because of some of the things we've already spoken about?
Well, yeah, I mean, yes and no. We wanted the manual therapy to be applied, to the lower thoracic, lumbar spine, sacroiliac joints, hip joints, right? We didn't want the manual therapy to be applied to the shoulder and the neck and the foot, um, but it was pragmatic in the sense that essentially the goal was to mobilize any stiff joints in this person's body, right, that were related to ambulation. So, the hip, sacroiliac, lumbar spine, lower thoracic spine. I mean, if somebody can't extend, then it's because of a lack of hip joint extension, um, mobilizing the hip joint, stretching out their hip flexor muscles, right? I mean, that's all part of that kinetic chain of motion. And that's exactly why we wanted them, our therapists and chiropractors, to be mobilizing multiple joints, not just restrict them to the lumbar spine. However, if they check somebody's hip joints and they seem to be fairly mobile in their hips, why force them into a protocol where they have to mobilize everybody's hip?
What has a clinician or has somebody who only recently kind of stepped out of the clinic, Does this study validate what you have been doing, or is this changing kind of your way of perceiving how these patients should be treated?
A little bit of both. I mean, I'll admit myself that
Mm-hmm.
until I started really getting into this area of lumbar spinal stenosis, as a clinician myself, I think I was underdosing my older adults. And I also felt,
Mm-hmm.
you know, I'll give it a try. I'm not sure if I can really help them or not. So I think as a result of
Mm-hmm.
seeing all these patients do better, including Carlo's patients in his trial, um, I feel more confident if I were to treat a patient with lumbar spinal stenosis. And it wouldn't be that I'd say to them, "Oh, I've got the cure," but I would say, "You know what? We've got pretty good evidence that if we mobilize your spine, get you doing some exercises, and if you agree to start using an exercise bike regularly, and that's a big part of this." Um, Carlo, in fact, when he sees patients, he's got a tough love attitude. He tells every one of his new patients with lumbar spinal stenosis, the first thing I'm going to do if I'm going to treat you, you have to agree to me and promise me you're going to buy an exercise bike and put it in your home. And if a patient
Mm-hmm.
starts waffling, he says, look, if you're really not committed to doing this, I mean, I'm telling you right now, we can't cure your stenosis. It's a lifetime condition and we can manage it and get you better. But if you don't ride that exercise bike every day, even for 5 or 10 minutes, I don't think I can help you. And I got a waiting list, so you can leave if you're really not committed.
I mean, that goes back to the contract concept that I know that Stanley Paris, when I was going through my training there, spoke of in his work. I believe Dr. Rainville had some sort of contract he would use for his protocol. So it sounds like a very similar type of model where you've got to really convey, I need buy-in. And if you don't buy in and you don't agree to that, then we're both wasting our time, which seems like a very legitimate argument and request.
Well, so I think that this gets to sort of a fundamental way of managing patients, older adults with chronic degenerative conditions. It's different than with just sticking to spine. A 75-year-old with lumbar spinal stenosis is different than a 35-year-old with a disc protrusion that centralizes with repeated extension. They're different kinds of
Mm-hmm.
patients, right? And or a 75-year-old with neo or hip OA that's not ready for joint replacement. To treat those patients for 6 weeks and then be done, and then say at 6 months, well, they're no better, there's no long-lasting effect to that. I think that's kind of disingenuous, and that's kind of what JAMA made us do, right? Well, there's no difference in 6 months.
Mm-hmm.
Well, guess what? They're all doing better at 6 months, and none of them needed
Yeah.
surgery. So why are all these people getting back surgery? Um,
Yeah.
why is everybody getting a joint
Yeah.
replacement? There are alternatives to these things, and it gets into this idea of sort of booster sessions, right, over time. That's something that's really not in the
Mm-hmm.
mindset of insurance companies or even um, healthcare
Yeah.
professionals.
I mean, we physical therapists still discharge patients as opposed to discontinue episodic care or uh, even the booster sessions. I currently do more of a direct provider model for my clinical caseload where I don't work with insurance companies. But when I did, a lot of what I would run into is kickback when I try to schedule a follow up 6 months down the road or even
Yeah,
three
because they
months
could.
down the road. Because now they had to go through the rest of you need to see a physician first, you need to go through additional healthcare expenditure just to come back and just give them a booster session, which is painful and
Well, yeah. So
ridiculous if you ask me.
my getting a little off topic here, but it kind of blends together. So one of my colleagues here is Kelly Fitzgerald at University of Pittsburgh, and they got an award for this at CSM. Right, his research is into doing booster sessions for knee OA, right? And he ran a trial that shows when the patients, if you gave somebody 12 sessions of PT and did, let's say, twice a week for 6 weeks and then be done, or give them those 12 visits more divided out over a year, they do better with periodic booster sessions compared to one big bolus of care. And that kind of gets to, I'm going to jump ahead here, but one of your questions people ask me all the time. So, Mike, you did this trial. If it was your mother and she had lumbar spinal stenosis, what would you tell her to do? Right? Which disease is the best? Just cut to the chase. Which is the best treatment here? And my comment is the combination of all three is the best. because a lot of these patients do have a lot of pain and they need some pain management. And so having a thoughtful physician manage their symptoms appropriately with the right meds and not give them opioids, which is a huge problem in older adults because they fall and they break hips and they die from opioids, or they have, you know, seizures, or they flip out on these meds. Why not be more thoughtful? That's one approach. Why not have everybody with lumbar spinal stenosis go through like a 6-week boot camp to kind of get them into shape and mobilize their spine, get them moving? But then for the maintenance, have them join, get a bike and have them join a community center where they participate in an exercise class once a week or something. And that's the maintenance schedule, right? And then maybe a booster session once in a while with their physical therapist or chiropractor. What's wrong with that? Why not combine all these
Hmm.
together, looking at it like, well, it has to be A, B, or C, which is best? Well, sometimes we lose sight of that the
Yeah.
combination might be better than any one by itself.
So, Mike, that kind of speaks to a little bit of momentum, for lack of again a better term here, where we're getting a little bit of a push towards trying to develop a different style of trial. The statement is that with a complex intervention such as chiropractic, such as physical therapy, that the randomized control trial is really providing a very limited amount of information given the grossly complex interaction that occurs with a therapist. I'm curious as to what your thoughts are on that.
Yeah, so this is, it's kind of like the research world's coming full circle. Many, many years ago, it was just like, let's compare if somebody sees a physical therapist to whether they see a chiropractor. Is one profession better than the other? People don't like those kinds of things, right? I mean, um, they seem kind of
Hmm.
antagonistic. Um,
Yeah.
but what I think is probably more important is this idea of more pragmatic trials. So, really, what you're speaking to would be
Hmm.
efficacy studies versus effectiveness, and especially pragmatic effectiveness
Hmm.
studies. And that's essentially what we did, right?
Hmm.
So, if somebody asked me, well, which manual therapy procedure or which exercise got these people better at 2 months compared to the other two, I can't tell you. All I know is that
Yeah.
if you see a physical therapist or chiropractor and they combine manual therapy and they do some individualized exercise, that package seems to work better than if they just go to those group exercise classes. Although group exercise helps, they're going to get better quicker. They're going to be walking further at 2 months if they have this more intensive approach. So
Hmm.
does it really matter exactly which procedure it is? And it's kind of this, I think it gets back to clinical trials have been based on a pharmaceutical model, right? Where you compare the experimental drug to a placebo. And now we're trying to compare
Hmm.
a single type of manipulation to a single type of exercise, but that's not what we do in the rehabilitation world. We do multiple things. And so I think we
Hmm.
have to compare package A versus package B. Or package A,
Hmm.
pull one thing out. If you think that one thing is so important,
Hmm.
pull it out and give everybody the whole package less that one or two things and see how much more they add value to the clinical outcome.
I mean, that makes sense to me as, again, more of a clinical mind as opposed to a research mind. So, Mike, the kind of to start closing things out a little bit, where's your research agenda taking you next?
So one of our current projects is now to take these results and try to actually implement them in the real world. That's another big problem with clinical trials, right? We publish this big paper, which is getting a lot of buzz. I wouldn't be on this podcast with you if people weren't interested, right? So we have a podcast, people listen to it, but if people don't actually implement this, what good is it? So we're submitting a grant for a dissemination and implementation grant where we're going to try to implement this study. And the way we propose to do it is to approach the primary care physician community in Pittsburgh with these results and find out what the barriers are to them making these referrals. We know for a fact that primary care docs are not making referrals to the physical therapists in our network. They're just, I shouldn't say they're not doing it at all, But we're finding that, for example, um, I forget exactly what the numbers are, but they're very small. I want to say about 20%, somewhere in that, and these are unofficial figures, but about 20% of our patients who have lumbar spinal stenosis who've had surgery, right? And we've interviewed a lot of them. They've had surgery. Kevin, you had surgery for lumbar spinal stenosis. Yeah. Did you ever have physical therapy before surgery? No. No. The majority of patients in our area have not even had a course of physical therapy at all. I mean, that's shameful. And it has to do with primary care physicians. We know what some of those barriers are, and one of them is a few of the ones we've discussed already. Well, I'm afraid they're going to get hurt.
Mhm.
They have osteoporosis, and if this physical therapist is doing manual therapy with them, they might break their bones. Well, guess what? That didn't happen in
Mhm.
our trial. It didn't happen in Carlo's trial. It's Can it happen? Sure, it could happen. A person could break a bone stepping off a step, but they're not being hurt in physical therapy clinics. There's a fear that the
Mhm.
exercise might bother them. That's an unfounded fear. So we're thinking that if we develop a strategy to get into primary care and dispel some of these myths, that we can get um, more buy-in where they're going to not just refer to physical therapists, but also get their patients going to community exercise. We also want to get them to
Mhm.
change their prescribing habits based on our results. So that's our next area, is an implementation science area, not another clinical trial. I don't think we need another clinical trial, to your point. We
Mhm.
need more implementation science type research. What are the barriers? We know something works. Why aren't people actually doing it in clinical practice? That's the kind of research I'm moving towards.
And that is an area that has a member of our clinical education team at my university. I am looking forward to seeing that, and I'm looking forward to seeing the outcomes from that work, because I know that we do a very thorough job of trying to teach our students evidence-based practice, and really trying to apply that to a true patient right in front of them, and then getting students coming back from their clinical experiences, and they have seen everything but that evidence-based practice in the real world.
This gets at your question before about clinical research trials. Is the randomized trial the best way to move forward with research? It's only one type of research, right? This idea of dissemination and implementation research is a new and emerging area that we're looking into. The other area that it's not very considered very sexy or hot, hot topic, but qualitative research is also very important. We've been doing that. We haven't published it yet, but I keep alluding in this podcast to the fact that we've interviewed in focus groups patients with lumbar spinal stenosis. We've interviewed clinicians, including chiropractors and physical therapists, about managing lumbar spinal stenosis. We're in the process now of doing focus groups with primary care physicians, physician's assistants, and nurse practitioners, asking them what their thoughts are about managing lumbar spinal stenosis. When you start interviewing people and scientifically putting that together in a qualitative research methodology, you it's amazing how much you can learn, because it's from those qualitative interviews where we find out why people aren't doing what they should be doing. All right? And that's the only way we're going to change clinical behavior, is by scientifically trying to understand where these barriers are. And then we can develop strategies to overcome the barriers. But unless we know what they are, it's very difficult to implement the results of these clinical trials.
And that does bring us back to a good correlation between clinical practice. You're not going to move forward with a patient without getting that patient's perspective of their current health status. So that application of that same clinical interaction to the research interaction through qualitative studies, I mean, it makes so much sense, but we haven't done it. And I was going to ask you offline if you were going to be doing some qualitative research based off of your comments earlier. So I'm
Yes,
glad to
we
hear
are.
that that's coming too.
So one of the reasons why we use the self-paced walking test as one of our primary outcome measures in the study was, before we started the study, we had focus groups with patients with lumbar spinal stenosis, and we asked them. We said, "Look, we're going to be doing we just got
Mhm.
funded to do a research trial, and we have to measure something that would be considered a success. So what would you consider to be, a success? We know you want your pain to go away or be reduced, but like if we had to measure something, what would you as a patient, what would be meaningful to you? And invariably, what the patients tell us, walking. I can't walk. That's my biggest problem. I can handle the pain. What I can't handle is the fact I can't walk, from my car to the supermarket door without grabbing a shopping cart. If I could just, walk to the door, I'd be happy. And that's when it dawned on us, well, we have to measure walking distance. You don't see that in clinical trials. Why aren't researchers measuring walking distance as an outcome measure? Because they never ask the patient what's meaningful to them.
Very good point. Very good point. Well, Mike, I have enjoyed reading this article and looking back across several articles that you've written. And from the sounds of it, I'm going to look forward to seeing several of your articles coming in the future. Now, I'm sure there's going to be some listeners that would like to ask you more specifics. Is there a good way for them to get in contact with you?
Probably the best way is to send me an email, which you could provide them. I could say it. It's my initials, M like Michael, J like Jacob, S like Schneider, the number 5, mjs5@pitt.edu. And I'll just give a disclaimer to that. I don't respond to emails in 5 minutes. I'm very, very busy. And so if you don't hear a response from me, in a week or two, it might be that it got filtered out by my email, or I was just too busy. And sorry, I'm a busy guy, but that's the best way to get in touch with me.
That works. I'm sure that our listeners will understand. Well, Dr. Schneider, it has been a pleasure talking to you. I greatly appreciate your time and your work, and I hope you have a wonderful rest of the day.
Same to you. Thanks, Kevin.
This has been a production of the American Academy of Orthopedic Manual Physical Therapists. You can learn more about the Academy by visiting our website at aaompt.org. You can also find us on Facebook, Twitter, and Instagram by searching for our acronym AAOMPT.